Dr. Ken Landa. Thanks for watching. Let's talk about Tricor or Fenofibrate. This is a drug that was FDA approved in 1993 to add to diet in order to reduce blood lipids and triglycerides. So what does it do? It reduces the total cholesterol, reduces the bad cholesterol, reduces the triglycerides, and it increases the HDL, or the good cholesterol. But in spite of all of that, it hasn't been shown to reduce the cardiovascular morbidity or mortality rate. In other words, it doesn't prevent death from cardiovascular disease. It's used pretty much for adults who have very high levels of triglycerides. But first, if you have very high triglycerides, you should try to find out what the cause is. Sometimes it's due to poor sugar control. If you have diabetes, maybe it's because you weigh too much, you drink too much alcohol, you have low levels of thyroid hormone activity. Maybe you're taking estrogen, birth control pill, or a thiazide diuretic, or a beta blocker. Irrespective of all of this, remember, even if we reduce the triglycerides, not going to save your life. The dose of the medicine, 145 milligrams, you take that once a day. That's the dose for primary hypercholesterolemia or for elevated levels of triglycerides. You check the blood at 4 weeks and again at 8 weeks. If the triglycerides aren't appropriately controlled after 2 months, well, then probably get off the drug because it isn't going to work. You can take the drug either with meals or without meals, and if you have any element of renal compromise, poor renal function, then you either have to reduce the dose or not take it at all. Now, there are 3 drugs in the family that have sort of the same side effects, the same clinical profile. They're Tricor, or Fenofibrate, there's clofibrate, and gemfibrozil. So if you have a side effect of any one member of the family, chances are you're going to have it in the other. So what are some of the side effects? One, the clofibrate study that was called the Coronary Drug Project that looked at people who had heart attacks and followed them for about 5 years and didn't find any difference in the mortality rate. But it did find that they had more gallstones. They had about 3% gallstones versus only a little bit less than 2% gallstones requiring surgery in the group taking the placebo. World Health Organization did a study with 5,000 individuals, no known heart disease, followed the people for the 5 years of the study and then 1 year after the study, and actually found that the people who took the clofibrate had a slightly higher death rate, total all-cause mortality, taking the drug versus taking placebo. Little less than 6% versus little less than 4%. The excessive deaths were due to malignancy, complications of gallbladder disease, and pancreatitis. Gemfibrozil, they did the Helsinki Heart Study, looked at about 4,000 middle-aged men, no history of coronary artery disease. They followed them for the 5 years of the study, 3.5 years afterward. And what they found, again, was total mortality was increased, but not significantly in the gemfibrozil group, and the cancer deaths were increased. Okay, so now let's get back to Tricor, realizing all of the drugs in the same family might have the same side effects. So 3 to 6 month duration studies of taking Tricor showed that the drug did modestly reduce the cholesterol by about 20%, the bad cholesterol by about 20%, boosted the HDL, good cholesterol, by about 11%. And the total triglycerides fell by about 30% if they started off at a baseline of about 190. Well, that's not very dramatic, but if your triglycerides are very high, say somewhere between 500 and 1,500, triglycerides should be less than 200 anyway. So if they're fairly high, then the drug seems to work okay. It reduces the triglycerides by about 55, 60%. So the triglycerides could go from, say, mid-700s down to low 300s. Well, that's pretty good. If the triglycerides are only moderately elevated, say between 350 and 500, it's going to make the triglycerides fall by, again, about 50%. So that's pretty good. But remember, if your triglycerides are very high, and as they get close to 1,000, that increases the risk for pancreatitis, you want to find out if you have a secondary cause, something that you can change to bring the triglycerides down. So remember, the alcohol, the drugs, the kidney disease, a variety of conditions. Well, how do you address high triglycerides? Well, certainly diet, decrease the fat you take in, maybe you take some fish oil, and then there are the fibrates. by themselves, remember, they don't cause a reduction in overall mortality. They don't decrease the non-cardiovascular mortality. But when they're added to statins, do they do any good? If the statins don't really work as well as you want, can you add the fenofibrate, the trichlor, and get better result? Probably not. But now we have an interesting trial. And this drug is going to get to be very interesting, as we'll talk about. So we have the ACCORD trial. The ACCORD lipid trial followed people for a little less than 5 years. It looked at about 5,500 type 2 diabetics who were already taking statins. And they gave some of them the trichlor, the fenofibrate, and others they just took the placebo. And there was a non-significant 8% decrease in the incidence of major adverse coronary vascular events. That means non-fatal heart attacks, non-fatal stroke, and cardiovascular death in people who were combining the statins with the trichlor versus people taking the statins by themselves. So overall, if we look at just the men, it seems that the men had some extra benefit. They had about 18% reduction in the non-fatal heart attack, non-fatal stroke, cardiovascular death. So that's pretty good. Unfortunately, the women had a non-statistical 40% increase in their risk of dying or having one of those kind of events. Okay. So then they did another study. It's called the field study. Looked at almost 10,000 people, followed them for 5 years. And again, they found a little bit of a reduction in the secondary outcome when they looked at the total cardiovascular events. Okay. But what they didn't find was a decrease in the total mortality. Actually, the total mortality rose in those people taking the drug, rose by about 11%. And there was a non-significant increase in the coronary heart disease death rate. So the total deaths and the heart-related death seemed to increase, but not statistically significantly. So in diabetics who have dyslipidemia, okay, that almost goes part and parcel. Diabetics, about 70% of diabetics, going to have increased triglycerides, and they're going to have low levels of HDL. And not only do they have abnormal lipids, they have small, dense LDL. And small, dense LDL are the worst of the LDL. So in 2019, the American College of Cardiology, American Heart Association said, hey, diabetics, you're at high risk. You ought to take something to reduce your risk of heart disease, since the major cause of death in diabetics is heart disease. And what they said is, take a statin. And if you have mild risk, take a mild or moderate intensity statin. And if you have a significant risk, take a high intensity statin. Okay. Well, one of the leading causes of blindness in working aged adults is diabetic retinopathy. So it's thought that you can reduce the diabetic retinopathy if you control the high blood pressure and control the blood sugar. They can decrease the incidence and progression of the diabetic retinopathy. But the hypercholesterolemia and the hypertriglyceridemia, results are really inconsistent. So when you take the statin to reduce your cholesterol, reduce your triglyceride, it really doesn't do much for diabetic retinopathy. But it seems like the fenofibrate, the trichlor, might. And that's the exciting part about this particular kind of condition or this particular drug. So the microvascular complications of diabetes involve the nerves, involve the eyes, and involve the kidney. And if we look at people who have diabetes, overall about 30% of them are going to have some form of retinopathy. It's going to be probably everyone if we look close enough in the type 1 diabetics. And if we look at type 2 diabetics, probably 80%, especially in people who've had the diabetes for at least 20 years. Recently, there's been a slight decrease, and that's because we're treating the sugar more aggressively than we used to 20, 30 years ago. But vision-threatening diabetic retinopathy is still a relatively common condition, caused either by diabetic macular edema or diabetic progressive retinopathy that has to be treated by the injections into the eye or laser photocoagulation. Well, those two recent studies that I just mentioned showed that independent of the effect of fenofibrate in reducing the triglycerides and reducing the cholesterol, it might prevent or at least retard the progression of diabetic retinopathy. The field study and the Accord study showed basically the same thing. They showed that the drugs were able to reduce the likelihood of progression of diabetic retinopathy in people who already have it. It won't prevent the development of diabetic retinopathy. But if you have diabetic retinopathy, overall there's about a 30% reduced likelihood that you're going to progress. So that sounds like it's pretty impressive for a drug that overall isn't very exciting. So if we look overall at the people who are taking the drug, yes, it reduces the cholesterol a little bit. Yes, it reduces the triglycerides a little bit. But the most important thing the drug does is it seems to prevent the progression of diabetic retinopathy. And so much so that in 2013, the Australian authorities actually approved it specifically for that purpose in type 2 diabetics who had existing diabetic retinopathy. So in America, for some reason, it's not really caught on. And additionally, not only does it seem to protect the eye, but it also seems, at least to some extent, to protect the kidney and to protect the nerves. So overall, we might have a good drug with fenofibrate. Additionally, what it might do is it might prevent amputations. So in the amputations for people who have microvascular, now it gets confusing a little bit because there are two types of problems that the vessels have. You have the microvascular and the macrovascular complications. Macrovascular complications are just the hardening of the arteries. Well, this drug doesn't seem to do much about that, but it does seem to do something about the microvascular complications. And the microvascular complications can lead to the amputation, especially of the toes or the foot. Well, the contraindications, people shouldn't take it if they have active liver disease or gallbladder disease, or if they have severe kidney disease or dialysis, women who are nursing, or people who are hypersensitive to the drug. Obviously, you shouldn't take it. The drug may, in some people, about 5%, increase some of the liver tests. Happens about 1% in people taking placebo. Usually there's no problem with that. You can continue the drug and the liver function tests seem to get back to normal. But rarely, after a period of weeks to years, there could be some sort of liver injury in a very small percentage of the people, so periodically you need some blood tests. And in some individuals, there may be some breakdown of the muscle, we call it rhabdomyolysis. So if you're taking the drug and all of a sudden you develop diffuse aches and pains in your muscles or unexplained muscle tenderness or some weakness, you probably ought to go and talk to your doctor. It seemed like maybe if you were taking a statin drug, it could increase the incidence. But now we think, well, it's probably just more unique to the gemfibrozil. But even so, you're probably at increased risk if you're elderly, if you have diabetes, if you have renal failure, if you have low level of thyroid hormone. And again, you check the blood tests periodically. Now, there's caution if you're taking a blood thinner like warfarin. You might need to reduce the dose of warfarin. And since there's more cholesterol that's going to be excreted into the bile when you take the fenofibrate, it might predispose to gallstones. So if you're at risk, you have to be extra careful. And then, of course, there are anaphylactic reactions that people can have if they happen to be hypersensitive to the medicine or its components. And in some people, they develop pancreatitis. And the question is the pancreatitis due to the elevated levels of the triglycerides? Certainly possible. Is it a drug effect? Certainly possible. Or is it because of too much biliary sludge that blocks the pancreatic duct? All of that's possible. So we don't really know what the association is. Does not increase the risk of deep vein thromboses, but might just by a little bit increase the likelihood of pulmonary embolism, 1% versus 0.7% of people taking placebo. So not a significant incidence. Blood count, well, it might be reduced in a very small percentage of people who are taking the drug, so again, need periodic blood monitoring. What are the standard kind of side effects? Well, there aren't really all that much different from placebo. The reason that people stop taking a placebo, well, about 3% because of the side effects, 5% because of the side effects from the fenofibrate. So really close to placebo. Some people complain of back pain or headache or some nausea, but that's the exception rather than the rule. After the medicine was on the market for a while, what they found was that, yeah, some people develop some muscle spasms or some rhabdomyolysis or some pain in the joints or pancreatitis, but the numbers are so small that that's not really a significant problem. Now, there is a problem in a very small percentage of the people. Instead of raising the HDL, the good cholesterol, might reduce the good cholesterol, down to 2 milligrams. You normally want it somewhere around 40 milligrams or higher. That's what we think might help protect you from having a heart attack. So low levels are of concern, and they can occur either shortly after you start taking the drug or for not appear till you've been on it for several years. So again, periodically blood checks. It can interact with some kind of medicines, but not usual. There's the warfarin I mentioned that you might have to modify the dose, and if you're taking a medicine like tacrolimus or cyclosporin, well, that can lead to other kind of issues. And if you're taking a bile acid binding resin, maybe a drug like Questran, you have to be careful because it's going to bind the fenofibrate, and both of them are going to go out in the stool, and you're not going to absorb. Well, there is a problem if you happen to take colchicine. Colchicine can increase the risk of muscle problems. And there's a little bit of an increase in the amount of a diabetic medicine known as glimepiride or proliferative, a cholesterol-reducing medicine. They're increased by somewhere between 10 and 30%. That's not a significant increase in concentration in the system. And by the same token, if you're taking Lipitor or atrovastatin, it's going to be reduced in your blood by about 20%. Limited data. If you happen to be pregnant, probably shouldn't take the drug. If you're breastfeeding, probably shouldn't take the drug. It's not really for pediatric population. If you happen to be an older individual or somebody who has impaired renal function, have to be a little careful of taking the drug. Liver conditions haven't really been evaluated. Interestingly, the fenofibrate is a prodrug. It's totally inactive. It has to be altered in the bloodstream. It's altered to fenofibric acid. Fenofibric acid is the active moiety. It's the active compound. Well, the drug works by dilating the vessels, by acting as an anti-inflammatory, by blocking the COX-2 enzyme that's important for aspirin function. It also seems to stop the death of some of the endothelial cells, the cells that line the blood vessels in the eye. Protects the pericytes, the cells around those blood vessels, seems to stop the leakiness of the retinal vessels. All of that very good. Well, additionally, it seems to reduce the level of uric acid, and it's anti-inflammatory from a number of standpoints, so it might have some extra benefit. When you take the drug, it's well absorbed. You can take it either with food or without food. About 60% of it's going to appear in the urine as fenofibric acid. About 25% is going to be in the feces. There's no unchanged fenofibrate that happens to be able to be detected inside the bloodstream. It's not going to be acted on by those liver drug enzymes, drug metabolizing enzymes that happen to be in the liver that we talk about so often, the 3A4 and the 2D6, unrelated to that. You reach a steady state in the bloodstream after you've been taking it for about 9 days, and that steady state is about twice as great as it is if you just took a single dose. Most of the drug, 99%, is going to be bound to proteins when it floats around in the system. The half-life of the drug is going to be 20 hours, so you only have to take one a day. As I mentioned, if you happen to have renal impairment, have to reduce the drug, and if you really have significant renal impairment, you shouldn't take the drug. In rat studies, it was shown that it might increase the incidence of liver cancer and pancreatic adenomas, and even testicular cell tumors, testicular interstitial cell tumors. Well, how much does all of this cost? Well, for 145 milligrams for a month supply, you could get it at Costco cash for $56. If you go to Walgreens, the same drug, the same amount is going to cost you $359. $56 at Costco and almost $360 at Walgreens. Doesn't make any sense. If you happen to have a coupon like you can get at GoodRx, you could go over to Walmart, get it for $24, or again, you could get it at Walgreens for $72, but if you make a mistake and go over to CVS, it's going to be $117. The brand name itself, the Tricor, that's $125 to $280 for cash, but if you have a coupon, again, free at GoodRx, it's less than $100. So Fenofibrate, is an old drug. It's mostly used to reduce the triglycerides, sometimes to reduce the cholesterol. But it might have new life. And it might have new life in protecting against some of the complications of diabetes, especially the diabetic eye disease, the proliferative retinopathy. Remember, it doesn't prevent the development of proliferative retinopathy, but it prevents the progression. And since we don't have much else that's easy and simple, other than an injection into the eye every month, it's very expensive. It seems that this relatively inexpensive drug has some very new and interesting potential. Something you should know about. Anyway, thanks for watching. If you enjoyed the show, please tell a friend, maybe consider subscribing so you'll be notified when we post new shows. I appreciate your interest. I'm Dr. Ken Landau.